Well, buenos días, good morning. We're going to begin the next roundtable, and we have here with us Mrs. Maura Harrigan, a registered dietitian and certified specialist in oncology and nutrition from the Academy of Nutrition and Dietetics. She completed her dietetic internship at the New York Hospital, Cornell Medical Center, and a Master of Science in Clinical Nutrition from New York University. At the Yale School of Public Health, Maura is the project manager of the Lifestyle, Exercise, and Nutrition, the LINK study, which evaluates the impact of plant-based diets and exercise on treatment adherence and chemotherapy completion rates in newly diagnosed breast cancer patients. Maura has also provided nutrition counseling at the Yale Cancer Center Survivor Clinic, one of the multidisciplinary clinics in the US, specialized in cancer survivorship. Maura, your turn. Thank you, Maura, for being kind. Next, I have the pleasure of presenting Estefania Toledo. I know her from her beginnings in medicine and in the specialty of preventive medicine and public health. She's a physician. She also has a PhD degree in 28. After her PhD, he has been in 3 times in the United States, one at Brown University and 2 stays at Harvard University. She works at one of the most brilliant departments of preventive medicine and public health of Spain in the School of Medicine of Navarra, north of Spain. She's main or co-principal investigator in many projects, including the Preventive Plus trial. He is also a co-principal investigator in the SAN, Seguimiento Universidad de Navarra, with almost 300 publications in that project. Well, it's a pleasure for me to introduce her here in Jaén.
So, good morning to everyone. First of all, I would like to thank the organizers for giving me the opportunity to be with you here today, and of course to Professor Delgado for his very kind introduction. So today I'm going to talk about extra virgin olive oil and its potential role in breast cancer and colorectal cancer prevention from an epidemiological perspective. I have enough conflicts of interest, and for my talk I would like to go a little bit upstream, looking not only at the potential role of extra virgin olive oil once the cancer has been established, but also its potential role as a tool to prevent cancer, that is, as to having people not having their cancer. As you know, extra virgin olive oil has healthy profile in terms of its fatty contents, with a high amount of oleic acid and a low omega-6 to omega-3 ratio. But in its extra virgin form, it also contains a plethora of minor components, which have shown to have anti-inflammatory and antioxidant properties, and also potential role for the prevention of different types of cancers. For the sake of brevity, I'm not going to talk much about the mechanistic aspects of these associations. I'm going to rather focus on the epidemiological studies on the associations that I previously mentioned, that is, on what has been observed so far in humans. Since I believe that the audience is a little bit heterogeneous and diverse, I'm just going to give you in 2 slides a 101 course on epidemiology. Okay, basically on the types of studies that we usually run, so that you understand some of the ideas that I've brought here for you. So these are the basic types of studies that we run, and they are ranked according to the quality of evidence they provide. Today I'm going to present mainly results on case controls, cohort, and randomized trials. So what's the difference between one and another? In case control studies, what we do is we recruit people with cancer, people without cancer, and we compare their previous exposures to see if any of those exposures, in this case, olive oil, may be associated to having or not that cancer. On the other hand, for cohort studies, what we do is we start with people who are disease-free, they do not have cancer, we collect information on their exposures, and we follow them up, we observe them to see how many develop cancer. These studies are what we call observational studies, because researchers do not do any intervention, we just observe and register what is happening, whereas in randomized trials, it's the researchers who assign who is going to be exposed and who is not going to be exposed to the intervention that is going to be addressed in that specific trial. And then we follow people a long time to see who develops and who does not develop the outcome of interest. And in each of these studies, we get one result, okay, one result per study. So when evidence progresses, we have several studies on a given topic, so we may want to combine different types of studies that have been conducted in a given area. And for doing that, we have what we call meta-analysis. Meta-analysis allow us to combine the results of individual studies. So each line here would represent an individual study. And then we have this diamond, which is the result that we get after combining these different studies. Then you see that we have this vertical line here around the 1. So as long as the diamond, to make this story short, as long as the diamond falls to the left of that line, that will mean that the exposure is inversely associated to the outcome of interest. That is, people who are exposed are less likely to develop that disease. So now let's go to a concrete example after this very, very dense 101 course. So this is a meta-analysis that was published earlier this year on the association of olive oil and breast cancer risk. They included different types of studies, prospective studies, that's the type of cohort study that we mentioned before, and case control studies. So let me start with the case control studies down here, and I brought this a little bit bigger for you. So if we look at the diamond, we see that this diamond slightly crosses that vertical 1 line. So we could say that those results are not really conclusive because the entire diamond is not on the left-hand side, which is what we would like to see. Nevertheless, if we take a deeper look into the studies that were included in this meta-analysis, we can make a difference between those which I highlighted in green and the other ones. What's the difference between those types of studies? The ones that I highlighted in green are the ones that we call population-based case control studies, whereas the other ones are hospital-based case control studies. What's the difference between one and another? The difference is basically on how the controls are selected. In hospital-based case control studies, patients who go to that hospital for a reason other than the outcome that we are studying and for a reason that is not suspected to be associated to the exposure are the ones invited to participate. So they are patients, they have other conditions. Whereas in population-based case control studies, controls are selected from the population, so they do not necessarily have other conditions. So to make it short, you may understand that population-based case control studies are better than hospital-based case control studies, or at least more robust to biases. So if we only if we only select those in green selected highlighted studies, and we combined only those, we can see that both the point estimate as well as the entire uncertainty surrounding that result falls below 2 to 1, suggesting that the odds of having a breast cancer is almost 40% lower if women had had a high olive oil consumption compared to those women with a lower consumption of olive oil. Nevertheless, I believe that it's very important to mention, and it's related to the previous slide that I showed you before, that none of these studies, please apologize for the typo, none of these studies made a difference between the different types of olive oils. That is, they only considered olive oil as a whole, no matter if the women in the study were consuming refined olive oil or extra virgin olive oil. And eventually, the picture might have looked a little bit different if they had made this difference. And what about the prospective studies? There are 2 prospective studies that were included in this meta-analysis. The one down here, the one which was conducted by Genevieve Buckland et al., it was framed within the EPECT study, which is a pan-European study which recruited more than 500,000 people. And they found no association between olive oil consumption and the risk of developing breast cancer. Again, it's important to mention that they did not make a difference between the different types of olive oil. The other one was a study that we conducted framed within the Preventive trial, and we did make a difference. We specifically addressed the potential role of extra virgin olive oil in its association with breast cancer. You are already familiar a little bit with the Preventive trial. By now, you already heard about it in previous presentations, but basically what we did is we recruited people on high cardiovascular risk and randomized them to different dietary interventions. The control group was advised to follow a low-fat diet, whereas the other 2 groups were advised to follow a Mediterranean diet. In one of the groups, they received for free extra virgin olive oil, 1 liter per week. And in the other group, they received mixed nuts for free, 30 grams per day. And how did we advise them to follow the Mediterranean diet? So what we call the 14-item screener, the META score, was instrumental for doing so. Basically, there are 40 keys for adhering to the Mediterranean diet according to this screener, and people get scored, get 1 point as long as they comply with a proper consumption of those foods which are considered as part of the traditional Mediterranean diet, and they also get 1 point as long as they refrain from eating those other unhealthier foods which are not considered part of the traditional Mediterranean diet. It's also a very straightforward questionnaire because it's a yes-no questionnaire, and you can provide very easily and very quickly feedback to your participants. Okay, these were the basic characteristics of the women who were recruited in this trial, and here I would like to show you something. Since the study was randomized, all the 3 groups were pretty well balanced in terms of their baseline characteristics. There were some small imbalances. What would we expect from those imbalances? Actually, if we look at this table, women in the Mediterranean diet group supplemented with extra virgin olive oil were slightly more likely to smoke, to have a family history of cancer, to have used hormone replacement therapy, to have had their menopause at later ages, and to consume a little bit more alcohol. All of these are considered risk factors for breast cancer. So, if anything, we would expect a higher risk of breast cancer among women who were allocated to the Mediterranean diet group supplemented with extra virgin olive oil. But this was the picture that we observed. Actually, it was those women who had been allocated to the Mediterranean diet supplemented with extra virgin olive oil who showed the lowest rate of breast cancer development during the 5 years of follow-up in the trial. If we see how this happened a long time, we see that women in the control group were those who were developing breast cancer at a quicker path than the other ones, whereas those women who had been allocated to the Mediterranean diet group supplemented with extra virgin olive oil showed the lowest risk of developing breast cancer. We went one step beyond, and we also used data from that trial as a cohort to assess the potential role of extra virgin olive oil in the risk of developing breast cancer. And what we observed is that the higher the extra virgin olive oil consumption, the lower the risk. How did we quantify this consumption of extra virgin olive oil? So we considered extra virgin olive oil consumption in terms of the percentage of the calories that come from extra virgin olive oil. So as long as the consumption of extra virgin olive oil was beyond 15% of the energy, the risk of developing breast cancer was significantly lower compared to those women who consumed a very low amount of extra virgin olive oil. How much of this? Well, the recommendation that we had in the Preventive trial was consuming 4 tablespoons a day of extra virgin olive oil, and that would allow you to be in this category in a standard 2,000 kilocalories per day diet. So we go back to the meta-analysis that I presented to you before, that is that study that combined the results of the different studies. They also ran this analysis, which allows us to see how the dose-response relationship between olive oil consumption and breast cancer risk may look like. Remember, they did not make a difference between the different types of studies because the original studies didn't make so. And how does this look for a 4 tablespoons a day consumption? Well, that will be around here. So as we can tell, there's no much evidence that allows us to obtain results for that type of consumption, because here, as you see, the uncertainty is represented with this dashed line. There's more uncertainty at these levels of olive oil consumption, so we would really need more studies to address the association of an adequate consumption of olive oil and the risk of breast cancer. What about colorectal cancer? I've only been speaking about breast cancer so far. There is one case control study on the association between olive oil consumption and the risk of colorectal carcinoma, colorectal cancer, which was conducted in Italy, and they observed an inverse association, suggesting that a higher olive oil consumption was associated to a lower risk of developing colorectal cancer. And that's it for the studies on olive oil. So is there anything else we can tell? Well, you are already familiar with the concept of the Mediterranean diet. The Mediterranean diet is characterized by a high consumption of fruits, vegetables, cereals, preferably as whole grains, moderate consumption of fish, seafood, dairy products, and wine with meals, and a low consumption of red meat and processed meat. But there are some misperceptions about the Mediterranean diet. So, what's not the Mediterranean diet? It's not a purely vegetarian diet. It does not include the American-style pizza. Okay? It's not a part of the traditional Mediterranean diet. It's not only about the amount of ethanol intake. It's also about the form, the way it's consumed. It's preferably consumed in the form of wine together with meals. It does not include fat-rich dessert preparations, quinoa, margarine, potatoes, tofu, or potato chips, and it's not the same as the Japan-Mediterranean diet or the Indo-Mediterranean diet. Those are not traditional Mediterranean diets. And what's in the center of the pyramid? Olive oil, ideally extra virgin olive oil. So, what may olive oil do in the frame of the Mediterranean diet? Especially extra virgin olive oil has shown anti-inflammatory properties, antioxidant properties, and anti-atherogenic properties. It's the usual source of fat in the Mediterranean diet, and the Mediterranean diet is pretty rich in fat. It's about 30–45% of calories come from fat. Extra virgin olive oil may represent more than 15% of the total energy intake in the Mediterranean diet, and there are two interesting things about it. One is that it replaces other unhealthier sources of fat. If we go for the extra virgin olive oil, then we will be avoiding other unhealthier fat. And it's also important to take into account its palatability. If you use olive oil for dressing your vegetables, then it's more likely that you meet your goals of eating fresh, tasty vegetables. So it's not only about consuming the olive oil in an isolated way, but also to include it within the dishes that you may cook. So, and what's about the evidence? What is there in the evidence about Mediterranean diet and breast cancer or colorectal cancer risk? So if we select the cohort studies that were included in another meta-analysis, which was also published earlier this year, they found that high adherence to the Mediterranean diet was associated with a lower risk of breast cancer. Nevertheless, I believe that it's important to mention that only 2 of all that list of studies were actually conducted in a Mediterranean country. So we may be a little bit dubious about really considering if the studies that had been conducted in non-Mediterranean countries actually captured the real Mediterranean diet. So we would need to put that in a question mark. And when they separated by premenopausal and postmenopausal breast cancer, it seems that the association was stronger for postmenopausal breast cancer than for premenopausal one. I already presented the results of the Preventive trial, so for the sake of brevity, I will skip that. And what about colorectal cancer? Again, and similarly to what happened for breast cancer, they observed an inverse association between adherence to the Mediterranean diet and the risk of developing colorectal cancer. But again, of this entire list of studies, only 1 had been conducted in a Mediterranean country. So we would love to see more studies like this, which can really capture the traditional Mediterranean diet. And what happens after cancer diagnosis? Is there evidence on the potential role that diet may play once the cancer has been established? So this is a study that was conducted in the US. From the ENHANCE study, they selected those women who had breast cancer, or other gynecological cancers. We'll be concentrating on breast cancer. And they did not find an association between adherence to the Mediterranean diet and survival after breast cancer diagnosis. But again, we need to take into account that that study was conducted in the US. So a high score in that countries which are not so familiar with the traditional Mediterranean diet may not purely reflect the actual traditional Mediterranean diet. In this other study, which was conducted in Italy, they included 1,453 women who had been diagnosed with breast cancer, and they followed them up for 15 years. And actually, they saw that women with a higher adherence to the Mediterranean diet, the ones represented in green, showed a better survival than those women with a lower adherence to the traditional Mediterranean diet. Interestingly, they also separated by the cause of death. So for all-cause mortality, there was an inverse association, but there was also an inverse association for non-breast cancer mortality, which is basically cardiovascular disease. And as we heard earlier before, extra virgin olive oil within the frame of the traditional Mediterranean diet may be beneficial for cardiovascular disease. And cardiovascular disease is in many cases, also the cause of death of women who have had a previous breast cancer. And what about colorectal cancer? So last year, this meta-analysis was published. When they considered all studies together, they actually found an inverse association between adherence to the Mediterranean diet and overall survival in colorectal cancer patients. And interestingly, they also separated the studies according to the time point where the adherence to the Mediterranean diet was assessed at. So if that assessment had been prior to the diagnosis or after the diagnosis. This is a very interesting thing, because if we could make a difference, we could give hope to patients. Doesn't really matter if you haven't had the best diet ever before. Now you can change your lifestyles, you can do something for your health. Unfortunately, the number of studies that have done so is still small, so we cannot really make sound conclusions on this. Then, more recently, this other large study with over 1,200 people was conducted in the US, and they found that a higher adherence to the Mediterranean diet was associated to a lower, to better overall survival in patients with metastatic colorectal cancer. So it seems that there may be something there, but still we will need more studies on this topic. So what's next? What are we working on now? So I'm really enthusiastic about telling you about our ongoing project, which is a randomized trial with women who had been just diagnosed of breast cancer. So before they have started any treatment, we randomized them to a Mediterranean diet intervention supplemented with extra virgin olive oil, which is provided by Olive Oils from Spain, or to the control group who is advised to follow a low-fat diet, because there was a previous study called the Women's Health Initiative study, which showed that women who had been allocated to a low-fat diet, who developed a breast cancer later on, showed a better survival than women who had been allocated to the control group. So we want to see which diet may work best once the cancer has been already established. Both groups receive an advice on physical activity recommendations, and for the time being, we are going to do a follow-up of up to 2 years, and we are going to look at adherence to the protocol to see which diet may be more easier to follow once women have been diagnosed of a breast cancer, because as we heard before, just because of the disease and because of the treatments, women may experience some difficulties in getting well nourished. So we will be able to tell which one is more easier to adapt to. We are also going to have some patient-centered outcomes, such as quality of life, and then some biomarkers of the prognosis of breast cancer. And I hope to be able to tell you about this in coming meetings. So I would like to thank all my collaborators before I finish, and of course you for your attention. Thank you very much.
Thanks, Estefanía, for your excellent talking. Well, we have time for several questions.
Thanks, Estefania, for a very informative presentation. My question is, in studies that have nutrition, a nutrition component, obviously the challenge is, how do you assess compliance and adherence to that nutrition, paradigm? Especially that becomes very important when you're looking at meta-analysis. And if you could comment on what goes into the assessment of nutrition and how does that differ? How does that affect the outcome of a meta-analysis that you presented?
Yeah, thank you very much. This is a very interesting question. Usually, information on diet is collected based on self-reported questionnaires. Those self-reported questionnaires have usually been validated, so they are considered to be good enough, even though we acknowledge that they have some limitations. Most limitations, nevertheless, go into what we call non-differential misclassification biases, so they can either go in one or another direction. So as long as it's that what's happening, then that would make it for us more difficult to find associations. So if we're able to find some signals despite those limitations, then we can be more confident on our results. Besides that, and then there are studies which only address diet once, and there are studies which just continuously monitor adherence to the diet. Those are considered to be better because they also help us to limit the misclassification bias. So for example, in Preventive, for the results that I presented on extra virgin olive oil consumption and the risk of developing breast cancer, we repeated those questionnaires on a yearly basis. So we continuously updated the information on their extra virgin olive oil consumption. And in Preventive specifically, this wasn't mentioned before, we also use some biomarkers of adherence to the intervention. We use a biomarker, urinary hydroxytyrosol for the extra virgin olive oil component, and plasma fatty acid component for the tree nuts. And we saw actually differences between the different groups also in terms of the biomarkers. So people changed their diet. Mm-hmm. Thank you.
Hello. You said that only 2 of the studies were in Mediterranean countries and 8 were from outside. Mm-hmm. And that concerned the studies that looked at extra virgin olive oil. How do you know that for those countries outside the Mediterranean, it actually was extra virgin? Because speaking from the UK, most of what you buy as extra virgin isn't. It's rectified.
So, actually, that was for the Mediterranean diet meta-analysis. So it was not specifically addressing only olive oil, but the entire dietary pattern. So it did not only consider olive oil consumption, but also all the other components of the Mediterranean diet. And as I mentioned, for the studies which specifically addressed olive oil, except for the Preventive one, they did not make a difference between the type of olive oil. So I believe it would be important to have other studies addressing not only replacing, for example, extra virgin olive oil with canola or sunflower oil, but also the different types of olive oil, because that would let us also know if it's basically the fat component that it's playing the role, because the fat component is basically same across the different types of olive oil. But the main difference comes from these other minor components, which have shown in vitro and in vivo studies potential effects for cancer prevention. So I believe that that would be very interesting, but hasn't been done so far.
Can I go? I have a question. First of all, thank you. I'm really learning a lot from both of you in this field. So speaker number 1, one of your slides, you said that one of the things you're going to be looking in your intervention with dietary intervention, prevention of cardiovascular disease, prevention of type 2 diabetes. Are you planning to put prevention of cognitive impairment? Because people still ignore the brain component. I'm very surprised, the benefit that the olive oil can have on the brain. Are you adding that in the future?
Well, definitely after listening to you today, yes.
Okay, great. That makes me happy.
Yes, and chemo brain, chemo fog is a very real consequence of cancer treatment. So yes.
Absolutely. So question for speaker number 2. One of your last slides, I think the study you're planning is very important, could really be very informative to a lot of things. How much extravaginal EVOO are you going to give? You don't say, you just say plus EVOO. How much are you going to give?
Half a liter per week. Half a liter per week, 0.5 liters per week.
Thank you.
Thank you very much, both of you. Maura, one, not question, I want to comment on something. In one of your slides, you had the polyphenols and in parentheses olive oil. And actually, I think we have, I don't know if Professor Thomaidis is here. Olive oil contains more than polyphenols. There are about, so far, I mean, he has a list of 3,600 phytochemicals that are existing there. So that's one thing that I want you to take into consideration. The second is a question. On your recruitment of the patients right now, are you biobanking blood as well?
Yes, we take baseline bloods post-chemo and at 1 year and at 2 years.
Excellent. Maybe we should talk about that, trying to get a second grant. Thank you.
Any more questions? Well, if there is no more questions, we can end this interesting roundtable. Thank you.